Good morning, everyone. Look like we have a quorum. Thank you for attending our DUR board meeting this morning. As a few reminder for our meeting today, if you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute the device via Google Meet. DUR board member, please reserve your question until the end of the presentation or ask in the Google Meet chat. For public comment, if you would like to provide a public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not member of the DUR board, please enter your contact information in the Google Meet or send an email to medicaid@pharmacy.utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you. I will leave that to Dr. Cannon.
Good morning. I'm circling my mouse around the mute button and still can't push it. So welcome to everyone. Looks like we will have a lively or interesting discussion this morning. So with that, I would call this meeting to order and welcome everyone in attendance. This morning, let's see, Noon, do we have any housekeeping we need to cover? No, you're muted.
Thank you for that. The housekeeping item is we have a new board member joining us, Dr. Caddington. Would you like to introduce yourself to the board?
Yes, good morning. My name's James Caddington. I'm a general dentist who has been asked to join the board, and I appreciate this opportunity and honor. I was a general dentist that practiced in Bountiful, Utah for 14 years before going to full-time academia at the University of Utah School of Dentistry, where I serve as the assistant dean for curriculum integration there. It's very nice to be with you all.
Well, congratulations, welcome. We appreciate your dedicating some time every Thursday morning for once a month on Thursday morning. So thank you.
Thank you.
Everyone should have received a copy of the minutes from last month. Were there any comments, questions, or corrections that anyone saw we needed to make? Kumar?
May I propose that we accept the minutes as drafted?
Do we have a second?
I'll second.
Thanks, Dr. Weinstein. All in favor of approving the minutes as proposed?
Aye.
Aye.
Any opposed? Okay, hearing no nays, the minutes are approved and we will move on. And so I'm not certain who from the University of Utah is going to be leading this discussion, but looks like Valerie. She just came on camera. So we will turn this over to the University of Utah. Thank you, Valerie.
All right, let me pull those slides up for you here. Okay, are those viewable? Okay, it looks like so. So today we will be discussing the agents approved for the management of general obesity and overweight. The scope of our report and review does not include the agent setmelanotide, which is for certain rare genetic disorders of obesity. The development and perpetuation of obesity stems from factors beyond personal choice, including environmental, socioeconomic, genetic, and psychologic contributors. Weight-related complications of obesity arise from the prothrombotic, pro-inflammatory, diabetogenic, and biomechanical effects of excess adipose tissue. Weight-related complications, which I abbreviate as WRCs, that are caused or exacerbated by excess adiposity include type 2 diabetes, dyslipidemia, hypertension, cardiovascular disease, non-alcoholic fatty liver disease, obstructive sleep apnea, and polycystic ovarian syndrome, among others. Clinical guidelines recommend screening patients with overweight or obesity for WRCs. Additionally, experts recommend population-level prevention efforts. Obesity has long been considered as a chronic medical condition by many health and medical organizations. In the US, obesity is estimated to affect 42% of US adults and 20% of the pediatric population. About 10% of US adults have severe obesity. To go along with the increasing trend of obesity over the past couple decades, weight-related complications have also increased in prevalence. Benefits of weight reduction among people with obesity can include prevention or improvements of weight-related complications, reduced risk for premature death, and improvements in quality of life. Weight reduction of 5% or more is a common goal since it is correlated with clinically significant improvements in cardiometabolic parameters, yet the benefits do tend to increase with greater weight loss from baseline, such as 10% or more, which can lead to improvement or even remission of some weight-related complications. BMI is a measure used to screen for excess adiposity. To arrive at a diagnosis of obesity, BMI should be considered along with other clinical factors such as age, gender, ethnicity, and body musculature composition. The 2016 guideline by the American Association of Clinical Endocrinology and American College of Endocrinology stages the severity of the patient's condition according to BMI and whether WRCs are present, as well as the severity of the WRC. Stage 0 is when no WRCs are present, whereas in stage 1, there is at least one mild to moderate WRC, and in stage 2, there is at least one severe WRC present. When considering obesity screening and management, guidelines recommend obtaining patient permission first to discuss risks related to weight. To reduce the risk of morbidity and mortality associated with excess adiposity and WRCs, clinical guidelines have long recommended lifestyle interventions. However, guidelines acknowledge that many patients are unable to engage in formal programs or are unable to achieve or sustain weight reduction and maintenance goals with lifestyle intervention alone. Overall, guidelines advise shared decision-making between the patient and caregiver for choosing the weight management approach. Before I go into the guidelines further, I'll introduce the pharmacotherapies. I'll refer to them as two categories: the early approved agents that were FDA approved prior to 1980 on the left side of the table. All of these are indicated for short-term treatment, whereas the newer agents on the right side of the table are all approved for long-term treatment. Each listed agent in the table, with the exception of liraglutide and semaglutide, are oral products taken daily or multiple times per day, depending on the agent. The GLP-1 receptor agonists, liraglutide and semaglutide, are subcutaneously administered. Liraglutide is taken on a daily basis, whereas semaglutide is administered on a once-weekly basis. All the listed agents are approved as adjunctive therapy to lifestyle modification. Additionally, each agent is approved for adults with obesity In other words, an initial BMI greater than 30. And the majority are also approved for adults with overweight with at least one weight-related comorbidity. Certain products also have a pediatric-specific indication for obesity. The indicated age for use is 12 years and older for liraglutide, semaglutide, phentermine with topiramate, and orlistat. The early approved products are labeled for 17 years and older, and naltrexone with bupropion is labeled for adults only. Gastrointestinal adverse effects are common with the GLP-1 receptor agonists, particularly when initiating treatment. Since these agents have glucose-lowering effects, hypoglycemia is also possible. So if patients are taking other glucose-lowering agents, those may need dose adjustment. Contraindications for liraglutide and semaglutide include a history of certain thyroid cancer or endocrine neoplasia. Liraglutide is also contraindicated during pregnancy. Common adverse events with naltrexone with bupropion are GI adverse reactions, dizziness, insomnia, and headache. This combination can also increase blood pressure and heart rate, so is contraindicated in uncontrolled hypertension. The bupropion component can also lower seizure thresholds, so this product is contraindicated in patients with elevated risk for seizures. Other contraindications include use in patients on chronic opioids or MAOIs. Common adverse effects with phentermine topiramate include GI events, neurological issues such as paresthesia, cognitive impairment, dizziness, and insomnia. In children, common adverse events in clinical trials included depression, dizziness, nausea, and arthralgia. Phentermine can also increase heart rate, so should be avoided in unstable cardiac or cerebrovascular disease, and is contraindicated with hyperthyroidism. This combination should not be suddenly discontinued since this can precipitate seizures. Since topiramate is a teratogen, it is also contraindicated during pregnancy. GI adverse events are common with orlistat, limiting its tolerability. This agent has the potential for interaction with many drugs and interferes with vitamin absorption. Orlistat is contraindicated in pregnancy and in patients with chronic malabsorption syndrome or cholestasis. The early approved products are contraindicated in patients who may be sensitive to sympathomimetic effects, in patients with history of drug abuse, and in combination with MAOIs. Common side effects with these agents are described as neurological, such as headache, insomnia, nervousness, and euphoria. Cardiovascular events include palpitations and hypertension, and there are some GI side effects. Each of the early approved products are controlled substances, along with the combination product phentermine with topiramate. So going back to the guidelines, this slide lists the organizations that have published the three most recent US guidelines addressing weight management pharmacotherapy for adults with obesity. This includes the American Gastroenterological Association, the VA, and the American Association of Clinical Endocrinology and American College of Endocrinology. All three guidelines support the consideration for adding weight management pharmacotherapy, which I'll abbreviate as WMPs, for adults with obesity or overweight with a weight-related comorbidity. Pharmacotherapy is recommended for use as add-on therapy to lifestyle modification and is generally supported as long-term treatment for the chronic condition. There is some variability among guidelines as far as when to start pharmacotherapy. The AGA suggested to consider pharmacotherapy following an inadequate response to lifestyle intervention alone. The VA's guideline concluded that there was insufficient evidence to make a recommendation regarding whether or how long a patient should first fail lifestyle intervention. And the ACE guideline takes into account the presence or absence of weight-related complications. So if a mild to severe complication is present and BMI is 27 or greater, the guideline advises the option to initiate pharmacotherapy and lifestyle intervention together as initial therapy. As part of the AGA guideline, authors conducted a systematic review meta-analysis and concluded that there was moderate quality of evidence to support the use of newer agents, such as semaglutide, liraglutide, phentermine, topiramate, and naltrexone bupropion. They did suggest against the use of orlistat for most patients due to its low effect magnitude and high side effect burden. Authors concluded that there was low quality of evidence with respect to use of the early approved agents, phentermine and diethylpropion. Guidelines advise that the choice of therapy should be based on the individual's clinical profile and needs, such as comorbidities, contraindications, drug interactions, the likelihood of adherence, preferences, and therapy access. There is variability among guidelines regarding the early approved agents. As I mentioned, the AGA noted low quality of evidence for their use while still considering them a potential treatment options. Whereas the VA guideline considered the evidence insufficient to recommend for or against using the early approved agents for short or long-term or intermittent weight management. And the ACE considered the evidence insufficient to recommend short-term pharmacotherapy in general. Guidelines by the American Diabetes Association and American Thoracic Society also express a place in therapy for weight management pharmacotherapy in patients with particular comorbidities, such as type 2 diabetes with a BMI of 27 or greater, obstructive sleep apnea with a BMI of 27 or greater, and in obesity hypoventilation syndrome. There are two relatively recent U.S. guidelines for pediatric patients with obesity addressing pharmacotherapy. The American Academy of Pediatrics recommends offering weight management pharmacotherapy as an adjunct to behavior and lifestyle treatment, and according to approved indications to adolescents 12 years or older with obesity. The guideline describes that particularly children with more immediate and life-threatening comorbidities, those who are older, and those affected by more severe obesity may require pharmacotherapy options. While not a key action statement or at the level of a recommendation, the guideline noted that pharmacotherapy may also be offered to children 8 to 11 years of age with obesity according to medication indications and the risk-benefit profile. Similarly, the Endocrine Society recommended considering adjunctive pharmacotherapy for children or adolescents with obesity after failure of intensive lifestyle therapy. I'll now review some of the considerations addressed in the report for developing potential prior authorization criteria. Refer to page 39 of the report for additional considerations. You may consider having an age restriction for each product according to the labeled indication. Patients may also be required to meet the labeled initial BMI for use and should have at least one weight-related comorbidity if being used for overweight. You may consider adding certain attestation fields for laboratory and counseling points. In particular, the labeling for phentermine topiramate recommends certain baseline laboratory evaluations, such as serum bicarbonate, creatinine, and potassium in all patients, glucose in patients with diabetes, and pregnancy testing if in applicable individuals, since this agent is contraindicated in pregnancy. We also provided important counseling points regarding when to take certain agents or nutritional concerns. For example, patients should be advised to take a multivitamin if receiving orlistat. And then you may also consider other informational, educational notes on the PA form, such as notifying providers that the use of the combination product naltrexone with bupropion may result in a false positive result on an amphetamine urine drug screening test. And lastly, if requirements are set for weight loss targets or weight maintenance dosages at the reauthorization, you may consider allowing space for the provider to express rationale for either lower maintenance dosages or reasons for more gradual weight loss. And I'll turn it back over to you, Dr. Cannon.
Thank you. We'll open it up to the committee. Any questions for Valerie? And Valerie, great presentation. Thank you. Okay. I think we've given everybody a fair chance here. So let me just pull up the agenda quick. We have several people today slated to give us public comment. So we will start with Novo Nordisk and Jessica. Jessica, please forgive me. I'm not going to try and pronounce your last name. I won't do that to you. Not typically, you have 3 minutes to provide your comments. Then the committee may have questions for you. Brian Larson typically times that. So Jessica, we'll turn some time over to you.
Perfect. Thank you. Are you able to hear me?
We can hear you.
Great. My name is Jessica Tradulius. Last name is not as scary as it seems, very phonetic. I'm a pharmacist and a medical account associate director with Novo Nordisk. And honestly, today, I just really want to thank you for your thoughtful and comprehensive review of anti-obesity medications and the guidelines regarding their use in folks with obesity. And I would like to offer to answer any questions you might have regarding Wegovy or Saxenda, which are the products that Novo Nordisk has.
All right. Go ahead.
Well, and if there aren't any questions, I'm happy to defer my time back to the committee.
All right. Do we have any comments or questions? Jessica, can you comment for me on, what does the evidence show when people discontinue one of your products? Do they regain the weight they've lost?
Correct. Yeah.
The evidence
Many of
show
the
there?
studies, yeah, we can definitely go there. In the studies that we have, most of them have a off product period after where we did continue to monitor them, and we did see some weight regain. And I think what this really points to is obesity is a chronic disease that likely does require some level of chronic management.
Great. Thank you. All right. From surgical and medical weight loss solutions, Dr. Medlin, happy to turn 3 minutes over to you for any comments. Let's see. Dr. Medlin, are you online? I am not seeing his name on the list. So we will move forward. So from Rhythm Pharmaceuticals in the University of Utah, Juliana Simonetti.
Yeah. Hi, good morning. And I work with I'm the co-director of the Comprehensive Weight Management Program here at the University of Utah. And for Rhythm, I only had done some consulting in doing education and genetics of obesity. Thank you so much for giving me this opportunity to speak with the committee this morning. So I am a physician trained in internal medicine, and I did a fellowship training in obesity medicine many years ago. I'm also board certified in both IM and obesity medicine, and I have been working in this field for the past 10 so years. I have started the Mountain West Obesity Society here in Utah, and I have been involved with some of the national organizations such as the Obesity Society, and I'm currently part of the American Academy of Clinical Endocrinology Obesity Treatment Guidelines Task Force, and they're working in revising that. And a quick background in how I got interested in the field of obesity medicine. So I was working
I'll remind you, you get 3 minutes, and then once that
I don't gain some extra from the other ones that pass. No, you
get 3 minutes. That's everybody else.
Yeah, so let me be quick. So I got interested because I was working in primary care, seeing a lot of patients that were coming in with kind of the exact same problems: obesity-related complications, hypertension, hyperlipidemia, diabetes, and obesity. And he felt that we were always addressing the complications of obesity, but not addressing the root cause of the problem. So I kind of went out and got this obesity medicine fellowship and feel very passionate about the work that I do. We know that obesity has long been recognized as a chronic disease similar to diabetes and heart disease, requiring long-term care, which was just talked about from Novo, in kind of a comprehensive approach that includes lifestyle, but also includes medication and surgical options. And unfortunately, we do not get coverage for the medical part. I feel like much has been advanced over the last decade since I started practicing, with the medications being a lot more effective for the treatment of obesity. And we know that lifestyle interventions alone, 85% of patients that try lifestyle interventions alone fail, and they regain their weight. And that's the experience we have had with many of our patients that come into our clinic. What I can tell you, that my patients do not choose to have obesity. A lot of them have severe obesity and many obesity-related complications. And what I'm seeing in clinic now is that patients at a much younger age are presenting with much more severe obesity and obesity-related complications. I have many patients now, they're pending transplant because they have NASH cirrhosis. And I really feel strongly that we need to have better intervention. We have the interventions and we need to be allowed to use them. Patients are desperate to get care, and they are not allowed to get care because they can't afford what's currently available.
Great. Let me give you the opportunity to comment on a few things that I guess are of questions of mine. And I think, within my organization, we've looked at a lot of the data behind surgical interventions versus pharmaceutical intervention.
Yeah.
And in terms of long-term success, and the economics of it, the surgical interventions appear to be more cost-effective over a longer term or longer period of time. Would you comment for the group on where you see surgical interventions falling versus pharmacotherapy? Yeah.
Absolutely. So I think it's important to have both options, right? And I understand your question in regards to the economics when you're looking at cost over a period of time. The thing to think about is that not everybody qualifies for surgery. We're seeing so many patients that actually do not qualify for surgery right now because they're very sick. The other thing is, with the newer treatments, the weight loss that we are seeing, even without surgery, seems to be very effective. That being said, we do have a comprehensive program where we feel that's really important to provide options to our patients. Not everybody will fall under the surgical category, and not everybody is going to but they might, and usually I do have that discussion with patients when they come in and they do qualify for surgery, that surgery is a long lasting and very effective option. However, even with patients that have surgery, sometimes you do see some weight regain. And what we are figuring it out now, that some patients have genetic mutations that lead to this, we call hyperphagia or metabolic changes where the body thinks it's starving all the time and kind of holds on to those calories. We are in really early phases on how we are in some of those discoveries, but I do see in the future where we might be able to do a lot more better target therapy. And there's more research now in this adjunct therapy with surgery and medication for some of the patients.
Great, thank you. We appreciate your comments. Any other questions from the committee? All right.
I have one quickly. So Dr. Simonetti, you saw some of the comments about the treatments for pediatric or the therapies for pediatric obesity. Any comments on those things that are missing or additional thoughts from you? Thank you.
Yeah. Again, and I'm an adult, I did internal medicine, but we are starting to see adolescents in our clinic. And the reason why we're starting, because the need is so great, in particular in Utah, there's not, some of the patients might have to go to Colorado to get the care that they need. So we're just starting to see adolescents absolutely outside of, based on needs, because those families are desperate to get help. And we're seeing young patients with much more severe disease. And so I really, in the trend now, even within the societies, have been to make the recommendations to start treatment younger, to prevent patients from getting the complications. I have seen an 18-year-old, with a BMI of 78 recently, that have obesity-related hyperventilation that's going to SLIC, and it just breaks your heart. The reason why he wanted to lose weight was to stop dragging his oxygen tank around and hanging out with his friends. Just the thought of that, right? And again, now that we're having more, we're also able to do genetic testing for some of those patients and trying to figure out if there's other genetic mutations and causes, because it is also unusual that some of the patients would have such severe disease at such a young age.
Great, thank you. All right. Dr. Rahman, pediatric endocrinology and diabetes, are you online?
I am, yes, thank you. Good morning, everyone. I'm Vana. Can you hear me okay?
We can hear you, thank you.
Wonderful, thank you. I'm Vana Raman. I'm a pediatric endocrinologist at the University of Utah and Primary Children's Hospital. Thank you for this opportunity to speak to you all and to attend this. I'm also the division chief for our endocrinology division, and I'm hoping to focus on the pediatric aspect of obesity. So I've been, in practice as a pediatric endocrinologist for the last 15 years. And I will tell you, over these years, not only have we seen a dramatic increase in obesity and the referrals, but one of the most frustrating aspects in my practice was I did not have a lot to offer them. And that is changing in the last couple of years. We finally have treatments that have shown, there's compelling evidence that shows that they work with significant reduction in body mass index, and we're finally making some headway and progress. I've referred a lot of patients to Dr. Simonetti because we did not have an obesity medicine specialist, but that is changing. As of June 1st, we have a new obesity medicine certified doctor joining us. What I will tell you, and this has been said multiple times, it's a chronic disease, but it's also a very complex chronic disease with both genetics and socioeconomic factors that play a big role, amongst many other hormonal issues that we don't understand. I will also say, amongst other things, we talked about physical complications. The mental health aspect is huge. I cannot tell you how many stories are shared where these kids are bullied and unfortunately have severe depression and anxiety and a much higher suicidal risk. These are adolescents, we're talking about, and children. So I think I think we have to offer them something more, because we know that lifestyle alone does not work, and we have decades of data. And finally, it's encouraging to see the American Academy of Pediatrics come out with a statement that really, for children 12 and older, in addition to intensive lifestyle behavior therapy, we have to offer pharmacotherapy as adjunct. They're not saying this is second line or third line. This needs to be on the very top as adjunct. And one last thing, I want to highlight the socioeconomic discrepancy. We know that the poor, the minority population, are at higher risk for obesity, but they're also the ones who have most challenges in getting these medications approved. It's the people who can afford it will even pay out of pocket, and they don't, it's not as much of a problem for them. So I think we would be doing a disservice by not offering, our most vulnerable population this. One last thing, obesity, we know in children is more severe. I see these kids who go untreated, and we know that they are at high risk from going from pre-diabetes to diabetes faster. And there's enough data to show that. And also the diabetes tends to be more severe in them. They get retinopathy, nephropathy at a much higher rate and faster compared to adults. And we have compelling evidence for that.
Great. Thank you. We appreciate your comments. I appreciate you speaking to socioeconomic factors. I think that's critical when we reflect on the population that we're charged with overseeing in terms of reviewing these therapies. So thank you for that. Any questions from the committee? All right. I will thank those that provided comment this morning.
Eric, just a quick question again. I'm sorry for jumping in again, but both for Dr. Simonetti and for Dr. Raymond. So intensive lifestyle is recommended. These medicines are adjunct to that. Should the policy be that the patients have to participate in order to access these medications? I know that sounds harsh, but is thoughts on that?
Go ahead, Dr. Raymond.
I will say yes. I think the idea is when we have our new obesity medicine doctor come join us, that we hope to have an obesity center, so to speak, where we offer dietary support, because I think that plays a role. I would advocate that if we can make that adjunct and not that you fail lifestyle first and then we would allow pharmacotherapy. I think they both need to be in conjunction, would be my suggestion.
Yeah, and I'll add on to that. So we currently have the comprehensive weight management, which really means we have registered dietitians, exercise physiologists, and behavioral health also being a really important part, as Dr. Rahman mentioned. I think the one thing to be cautioned is that access to registered dietitians, right? We have it in our clinic, and even then it's hard to meet the needs for the whole population. We start doing classes because we just can't see everyone that comes. The idea would be to see everyone, every X number of months for the registered. We just can't. So we have started doing classes and trying to be more creative in how to meet our patients' needs. So just, you have to be careful when you make those requirements. I think is necessary. I think the lifestyle, and in particular, when you're talking from a younger, or even, any kind of intervention, you have to do lifestyle modifications. And the medication alone is only going to get you to a certain point, but you do have to work on that as well, but being cautious with, how many do you have to actually take the insurance, or maybe as the insurance providing some kind of education for dietary education, or encouraging increasing physical activity.
Well, we appreciate that, because we are always mindful of access to care issues for our rural members across the state. So thank you for those thoughts.
So my name is Dr. Brian Moores. I'm one of the practice partners of Dr. Walter Medlin. I'm a surgeon in bariatrics. Could I give a quick answer to that last question and maybe give some additional surgical recommendations?
Yeah, you bet. I think, and Brian and Joe, I'll look to you guys for guidance there. Can we recognize him as representing Dr. Medlin, since that, or do we need the conflict of interest statement and things on file?
We will need a conflict of interest statement. Noon, if you want to, I mean, I'll let you address it, but whether or not we get it after the fact or not, I'll leave that to you, Noon.
Yes, Dr. Moore, if you can send us the conflict of interest form after this meeting, we will appreciate that. I can reach out to you and send you the form.
Thank you. I do have it, and I can fill it out and I'll complete it. My name is Dr. Brian Moores. I'm a bariatric surgeon. I also have additional, so I'm board certified in the American College of Surgeons with general surgery, and an additional year of bariatric specialty training in revisions, conversions, and also medical weight loss. I also carry additional specialty training in robotic Da Vinci surgery, as well as advanced therapeutic endoscopy. There's just three things I want to talk about obesity. Number one is it requires multidisciplinary care. So there is very few things in medicine that we treat like obesity. So in cancer, we use surgery. So in cancer therapy, we use surgery, chemotherapy, and radiation. And we use them in conjunction to have the most effect. The one thing that we do in obesity that is incorrect is that we use our least effective treatment first, diet and exercise. Diet and exercise is only 5% effective at 5 years. It is the least effective tool we have. And what I would caution you on is if you require that patients do diet and exercise before they qualify for medications or surgery, it will be gatekeeping. And there is very poor evidence that people that do 3 months, 6 months, 9 months, or 12 months of diet and exercise will have success, or that it will increase their ability to be successful long term. So I apologize, I'm very emotional on the subject, but I would be very careful about requiring that. The one evidence that we do see is that for prehabilitation, so for people going to surgery, if you can achieve a certain amount of weight loss before surgery, it will decrease their surgical complications, but it does not change your success rate long term. So definitely diet and exercise is important. Lifestyle change is very important in having success, but often delays care and allows for progression of disease and other associated diseases like diabetes. So I am against mandatory diet and exercise for a specific length of time. So that's hopefully answers that question. The second one about medications and weight regain. There are 3 patients that I specifically see medications as particularly useful in my practice. One is there are patients that don't qualify for surgery. 2, there are patients that have had surgery. There are 5 different options. They have varying success rates based on the patient's indication. But particularly for the weaker surgeries like sleeve gastrectomy or adjustable gastric band, patients will continue to have metabolic disease, patients will continue to have obesity, and they'll need options long-term or in the future. So that's the second group. And then the third group are patients that may have had a surgery and they have chronic obesity and they have no surgical revision options. They can't be upgraded to another option. So again, I view this as chemotherapy, radiation, and surgery is that obesity, we have to treat it before surgery, we have to treat it after surgery, and it's a chronic issue. And then lastly, surgery, for the efficacy of surgery versus medications, nothing is more effective than surgery. So surgery is 95% effective at 5 years. Medications historically for the older medications had been 25% effective. Compliance, continued use at 5 years. Diet and exercise, 5%.
That's time. Thank you.
Thank you.
Dr. Moore, thank you for your comments, and I think we appreciate you jumping in. You talked about not using diet and exercise first before surgery. I've noticed over a period of time that as we've promoted this, and you look at some of the centers of excellence around obesity, a lot of them require that the patient lose a certain percentage of weight on their own before surgery. Is that something of the past, or is there something, in terms of the centers of excellence across the country, where does that fit? And it seems to be kind of contrary to your statements. So I just wanted to follow up on that.
Yeah, great question. I think that's a great question from multiple bariatric surgeons. We talk about this yearly at our national conferences, but ASMBS specifically has released, that's our national accrediting body, has specifically released that they do not think that mandatory preoperative weight loss should be included, nor should it be allowed by insurance companies. The data for mandating that shows that those patients, if you mandate it, they're simply lost to follow-up. They simply don't proceed with further medical or surgical care, and it ends up becoming a barrier that some portion of patients are unable to achieve. And I would like to talk more about our endocrinology and our medical team, is that there simply are some patients where their genetics, their metabolism, and their environment are simply much too strong for diet and exercise to be an effective tool. So I think it's, the ones I see sometimes are 3 months of mandatory diet and exercise. And I think it's important to train patients and to provide those tools and have a multidisciplinary approach. But there is a very real risk that 40 or 50% of your patients will never achieve weight loss. And then you marginalize that group from ever receiving either medications or surgery. So what I would tell you is I would think it's important to do that. But if they're not successful, we can't remove those resources that they need. And so we still offer surgery to those patients. We just talk that if they can lose weight, it's going to increase the success of the surgery or decrease their complications. But I would still continue to offer them those tools, even if they cannot lose weight.
What's the role of mental health before, after, during kind of the surgery process?
I'm not a mental health expert, so I probably won't be commenting on that. I would tell you that patients with mental health disease can have equivalent outcomes and that they don't have increased complication rates as long as their mental health disease is well controlled and that they have a team that is managing it actively.
And I'll add on to that comment too. For our comprehensive weight management program, we do have psychologists, PhD psychologists who work with our patients closely. I think and Dr. Morris can comment on that too. At least I think for most bariatric programs, they do require psychiatric evaluation. But as long as they have supportive, it doesn't mean that it completely blocks them unless they have had more recent active suicidal ideation or suicidal attempt or psychiatric hospitalization. And then they just have to make sure that they're having the treatment and having the support that they need to go through surgery.
Great. Thank you. Dr. Weinstein's having some technical difficulties, and she emailed me thanking all of you for taking some time to talk with us today. She appreciated the fact that you've brought up social determinants of health and the economics, socioeconomic factors involved in this. So big thank you to everyone that's commented this morning. We appreciate you taking the time and joining us. So we will move forward with the discussion as a committee. Noon, can you give us some guidance and direction in terms of what you want us to accomplish as a committee in terms of this discussion? I know in the provider manual, it indicates that weight loss is not a covered benefit or service within Medicaid, although I know that may be something you want to add in terms of coverage. So can you give us some guidance there first?
And Eric, Dr. Siegfried has her hand up too.
Oh, I am so sorry. Dr. Siegfried, we'll just go straight to you.
Well, I just wanted to, because I actually, when I was working with the Department of Health, I was asked to draft guidelines regarding psychiatric screening prior to surgery for obesity. And, I concur that there are very few psychiatric, contraindications to the surgery in terms of things that, would preclude someone just solely based on a psychiatric issue from surgery. I also agree with both Dr. Morris, Dr. Rahman, and Dr. Simonetti that both the psychological toll that this takes on individuals, as well as, sort of it's almost a bidirectional relationship between, mental illness, especially anxiety, depression, and, obesity, both in adolescents and adults. is something that we do, need to bear in mind as well in terms of adding to, costs of care, as well as just overall, generally, the health of our Medicaid population.
You're muted, Eric.
We'll just go back and forth then with making sure neither one of us mute today. Thank you, Dr. Siegfried. We appreciate that input. Noon, tell us what to do.
Yes, so before we head on to the discussion, I would like to share with the board about the rejection that the Medicaid has seen for the last year for these pharmacotherapy medication for weight loss. So within the last year, from January 1st, 2022 to December 31st of 2022, we have received 207 rejected claims for diethylpropion, one for phendimetrazine, and 3,000 for phentermine, and 32 rejected claims for the combination between phentermine and topiramate, 161 rejected claims for Saxenda, 320 rejected claim for Wegovy, and 62 rejected claim for Orlistat, and 118 rejected claim for combination of bupropion and naltrexone or Contrave. So we do see that there is the need for these medication. We appreciate the review from Valerie today and all of the public comment that come to the meeting today. And even we are taking into the consideration of expanding the weight loss coverage on the Medicaid side. We are not yet making the decision at the moment, but we do notice that there is the need for these therapy. And I want to point out that even though at the moment Medicaid doesn't cover medication for weight loss, there is a pathway to have these medication covered. We did approve a Wegovy through the medical necessity pathway a while ago for a member under 18 years of age. So there is a pathway, but in general, we are considering extending the coverage for that. There won't be a need for a motion from the board today.
Great, thank you. And the data you presented represents claims that were submitted to fee-for-service and not inclusive of rejections that may be seen presently with the ACOs. Is that correct?
That's correct. Only these are exclusive to fee-for-service.
All right. Comments from the committee in terms of weight loss, the number of rejected claims that the state is seeing. I know we are seeing within Select Health significantly more rejected claims than we've seen previously as it relates to semaglutide. But thoughts from the committee in terms of coverage for weight loss and any comments in terms of guidelines where coverage might be best provided. Okay. Go ahead, Kumar.
Well, after listening to all the experts, as a citizen member, I feel that just because we cannot agree on some strict template guidelines, that does not mean we should give up. So my point is that we should try hard to see if we can work on the comprehensive, like Dr. Simonati said, and the mental aspects that Dr. Raman brought up, because obesity results in a lot of other things that we might not know, at the moment. So we can't give up, and I think we should repeat this kind of discussion maybe in 6 to 9 months. And in the meantime, Negan can also, work on it and do a little extra research or whatever needs to be done. And
All
that's
right.
Yeah. Thank you.
All
I
right.
had a question for Brian. I noted that next week PNT is taking up the anti-obesity treatments as well. Will it take a change from the legislature to mandate coverage for these medications, or is it something within Medicaid itself?
Our current restrictions are not legislation, it's rule. So it would require a rule a change in rule. And so that's something that, that's why we're having this discussion, is to discuss the ramifications and take that into consideration. And of course, there's a number of factors that go into making a rule change.
So Brian, does that require a waiver from CMS, or is this a state-specific issue?
No, it's not a state plan amendment, so it wouldn't require a waiver from CMS. It's a different process that would be started internally. There's a public notice and public comment period, and approval from senior leadership at the division is sort of the process that is required for a rule change.
Great, thank you. We appreciate that, Brian, and I think that helps us as a committee. I think all of us as clinicians and Kumar as our faithful citizen representative, I think see a need for some options in terms of treating obesity. I think clearly there are some issues that I think you as the department will need to address in terms of your fiscal and fiduciary responsibilities to the state, and the parameters that you've been given to work within. So I think we as a committee would be supportive of, whatever it is that you as the department decide to do in terms of coverage of these products. I think, clearly, given what we're seeing in the market, there would need to be some fairly significant controls, at least in my mind, in terms of, who the treatments are approved for, and under what circumstances. All right. Hearing no other comments and seeing no hands raised, Noon, if we don't have anything else, I'm going to call for a motion to adjourn.
Yep.
All right. Do we have a motion to adjourn? Kumar, thank you. We have a second.
Second.
Thank you, Colby. We appreciate that. All in favor?
Hi.
Aye.
Great. We got a clear blue sky and some sun. We may not get real warm, but go outside and enjoy the clean air. Hey, thanks everybody. We'll see you all next month.
Thank you.
Thank you.